This is part 2 of the modality topic for abdominal radiology. The topics are again based on the National Medical Student Curriculum in Radiology. We will be reviewing ultrasound, CT, and MRI, evaluation of the solid abdominal structures in the abdomen, including the liver, gallbladder, kidneys, pancreas, spleen, and vessels, IVC, and the aorta. Ultrasound is not good for evaluating bowel because of bowel gas, which interferes with the acoustic waves. There are certain advantages for ultrasound. Specifically, there's no radiation. It's portable and it's easy to do. However, there's limited field of view. So if there are pathologies involving the entire abdomen or pelvis, you would only have a very limited evaluation of that. Common but not comprehensive indications include right upper quadrant pain to evaluate the gallbladder for cholecystitis, hepatocellular carcinoma screening for patients with cirrhosis, fibrosis, and it's again very limited evaluation for abdominal pain because you're looking specifically at these structures. So if you're suspecting the pain to be something beyond these specific structures, then CT, abdomen, and pelvis with IV contrast is more appropriate. These are examples of some of the structures that we get. The first one is the liver. This is by the IVC. Here's an example of the gallbladder, which looks normal. This is the gallbladder here. And you see the wall is thin. There's no pericholecystic fluid. We can also look at the CBD here. It's not dilated. And we can look at intrahepatic biliary ductal dilatation, and all of that is normal. These dark lines here are the hepatic veins. We look at the pancreas here. This is the pancreas over here. This is the splenic vein here, this dark hypoechoic region. We can evaluate the kidneys and the spleen. The spleen is here. And then we can look at the vessels. So aorta, and then we can look at the IVC. We can look at the aorta for ectasia, aneurysm, and then IVC. Another type of ultrasound exam is the renal ultrasound. And for this, the kidneys and bladder and limited evaluation of the prostate are performed. We cannot, or we do not include the bowel or other solid structures within the renal ultrasound. Typically, patients will be getting renal ultrasound if patients have AKI, acute kidney failure, and when they're looking for obstructive causes from, for example, stones. Here's an example of the kidneys. So we have the right kidney and then the left kidney. This is the normal fat in the renal sinus. This is the normal parenchyma, this hypoechoic dark band, and both of these demonstrate normal kidneys. This is an image of the bladder. This is done transabdominally. This is moderately decompressed bladder. This is the normal bladder ultrasound. We can also perform pelvic ultrasound. This is really great for women presenting with pelvic pain, where you're suspecting a GYN source. And the structures that are evaluated are uterus, the nexa, and the pelvis. We do not evaluate the bowel or other structures in solid organs in the pelvis. And common indications for pelvic ultrasound include pelvic pain, abnormal uterine bleeding, and if the patient is pregnant, for example, they may look for ectopic pregnancy or intrauterine pregnancy, etc. Here's an example of a pelvic ultrasound. This one is transabdominal. You can see that there's a curvilinear shape to the transducer, and the uterus is highlighted in yellow, and then the endometrium is in purple. This is a transvaginal evaluation, and you can see that the transducer here is a lot more curved, and we see here a better visualization of the uterus and the endometrium as well. Transvaginal evaluation is optimal. We get the best images through the transvaginal evaluation. But we do both transabdominal and transvaginal because some structures are better seen on transabdominal, for example, depending on where the ovaries are. Here's an example of the right ovary. This is hypoechoic region, and we can do a spectral flow to assess the arterial flow. The size and morphology looks normal. So this is the normal pelvic ultrasound. Another study that we can do is contrast enhanced ultrasound. It's FDA approved now for abdominal applications for example, guidance of procedure like biopsy or ablation, and also characterization of lesions. So here's an example of a 16-year-old girl with a history of biopsy-proven angiomyolipoma. Here is the mass in the left lobe of the liver. Because this is a child, we want to limit radiation exposure for follow-up studies. So one option is to do a contrast-enhanced ultrasound. So here, on a follow-up routine evaluation, the mass is here. It's hypoenhancing, and it's smaller. What you'll notice about contrast-enhanced ultrasound is that it's dynamic. So you'll see the contrast light up the liver, and then eventually it will wash away as the blood clears from the liver. So we can characterize liver masses using contrast-enhanced ultrasound because it's a dynamic evaluation of the enhancement and washout of either masses or lesions that you're trying to characterize. CT abdomen and pelvis is another modality that we use commonly in abdominal evaluation. The structures that we evaluate include the lung base, solid organs, bowel, bones, and soft tissue. This is the workhorse of evaluating patients, typically with abdominal pain. It's done for many, many reasons, and common ones are abdominal pain, any location. We can do multiphasic studies to look for characterizing masses, and enterographies to look for small bowel pathologies. The advantage is that it's very fast, consistent. It doesn't matter what. Typically, it's independent of institutions and scanners. And we typically get very high quality images, and it's not operator dependent like ultrasound. The disadvantage, of course, is radiation. But now there's new reconstruction algorithm that reduces the radiation exposure to patients compared to before. Here's an example of a CT abdomen and pelvis with contrast. You can see the vessels are lit up, and there's oral contrast. So the small bowel, there's this dense stuff that's barium that has been taken per oral, and this is a normal abdomen and pelvis, and so you can see the entire abdominal structures. In contrast, here is an example of a patient who presented with left lower quadrant pain, and you can see there's thickening and stranding around the sigmoid colon, and that's in contrast to the normal sigmoid that you see here, where there's normal wall as well as normal surrounding structures. Here there's stranding and there's thickening in the background of diverticulosis, consistent with acute diverticulitis. With CT, we can do multiphasic studies. So here's one example of a multiphasic study looking specifically at an liver mass. So this is a pre-contrast, and we can scan the patient again on arterial phase, and we see this mass enhancing. And then on venous phase, we see this mass washing out. So this is diagnostic for HCC. We call this LIRADS 5. There are 5 categories, 1, 2, 3, 4, 5. 5 means it's definitely HCC, and patient can be listed for transplant. Another CT scan that we can do is called CT colonography. We insufflate carbon dioxide, CO2, into the colon to distend it, and then we can do a virtual colonography and look for colon cancer. This is accepted as an alternative to invasive colonoscopy for screening colon cancer per USPSTF. A quick note about contrast. For CT abdomen and pelvis, we use IV iodinated contrast. Anyone with GFR of greater than 30 can get iodinated contrast. In fact, the requirement for GFR is only specifically for individuals who are 60 years or older, who have solitary kidneys, for example, if they had prior kidney surgery, if they have diabetes, hypertension, or are on metformin or other hypertensive medication. If the patient is young, doesn't have history of hypertension, diabetes, then they don't need creatinine evaluation or GFR clearance. They can just get the CT abdomen and pelvis without having their kidney function checked. So again, kidney function only needs to be checked in high-risk patients. So patients who are older, greater than 60, patients with diabetes, hypertension, on hypertensive meds, and patients with solitary kidneys or CKD. Everyone else can get IV iodinated contrast without checking renal function, per the 2018 American College of Radiology Contrast Media Committee guidelines. The contrast, we typically don't give IV contrast for patients who are presenting with suspicion for renal stone in a person with a history of renal stone. If they do not have a history of renal stone and they're presenting with flank pain, then you want to get a routine abdomen and pelvis with IV contrast because there are other causes of flank pain. Also, patients with severe contrast allergy who cannot be premedicated, for example, because they're unstable and they need stat CT abdomen and pelvis, should not get IV contrast. So in patients who cannot get IV contrast, we typically want at least oral contrast to be given. Another study you can order is CT with and without. So pre-contrast followed by contrast enhanced CT. There are only 5 indications when you need a with and without. They're per American College of Radiology. And those 5 indications are CT urogram, for example, to look for hematuria, renal mass, adrenal mass characterization, liver mass characterization in non-cirrhotics, so young people with liver mass, you want to get a with and without, and patients presenting with GI bleed. All other indications, for example, AAA evaluation, AAA rupture, cancer evaluation or staging or follow-up, pancreatic mass evaluation, we don't need a without a pre-contrast for that. And this is important because we want to reduce radiation to patients when needed or when not needed. We can also provide oral contrast. This is something that the patients drink, and there are different types of oral contrast: positive, negative, and water. Water is a type of negative contrast. We saw earlier, this is a case of positive oral contrast, and we call it positive because it's bright. Another type of contrast is called negative contrast. This is an example of a CT enterography and with negative contrast. So you see that unlike the earlier image, the contrast in the bowel is dark or gray. This is volumen or sorbitol, and this helps distend the bowel. And this is really great for evaluating bowel abnormalities. So, for example, we see here some bowel wall thickening compared to the normal bowel wall. And there's a little bit of combing here in a patient with Crohn's. A little bit of thickening here as well and here. So this is a form of negative contrast. So if there's any concern for small bowel abnormality, then you want to order negative contrast. Typically, patients presenting to the ER and urgent care, we don't use oral contrast. But if you're concerned for perforation, fistulas, or leaks, then we want to get oral contrast because that will highlight the area of concern better than if you don't have contrast on board, oral contrast on board. The last imaging modality that we're going to review is MRI abdomen pelvis, and we're evaluating the same structures as we do with CT, but there are important differences. So MRI has very high soft tissue resolution. We can do similar multiphasic studies, but in addition, we can do functional imaging as well. And we'll show you an example following. However, it takes much longer than a CT. A CT scan takes a minute to 10 minutes, depending on the type of study that you're doing. An MRI, you're asking at least about 15-20 minutes and longer, depending on the study that you're doing. Patients who have claustrophobia may need to be premedicated with anti-anxiety medications or may not be able to get this. If the patients cannot stay still, that's important to know because patients, we will not get very good images. And so you want to try to consider some other things like CT. Here's an example of MRI. This is an MRI with MRCP. MRCP is it's a study we do to evaluate the bile ducts. Here we see the MIP images, and we can see the intrahepatic and the CBD as well as the gallbladder really well, and we see that it's very dilated, and it's dilated due to a pancreatic mass at the pancreatic head that you can vaguely see right here. We can do other things like fat iron quantification. So NAFLD, non-alcoholic fatty liver disease, it's an epidemic now and is going to supplant hepatitis as the leading indication for liver transplant. So identifying that early and reversing that is really important. In MRI, we can do a sequence called in and a post-phase imaging. This is the in-phase imaging, and this is the post-phase imaging. And we're looking for intracytoplasmic fat. So here we see that the patient, the in-phase imaging is bright and then it becomes dark on a post-phase imaging. This is consistent with steatosis or fatty liver, and we can assess the degree of it and quantify the percentage of fatty liver. In contrast, this is normal. This is in phase and in post phase. Normal liver should not have intracytoplasmic fat, and in this patient it does. So that's one way to use MRI, depending on the clinical context. MRI can also be used to assess for rectal cancer, for staging before surgery or after chemoradiation. This is not something that CT can do because it has limited soft tissue resolution. But here we see this rectal mass over here, and we can determine if the patient has a T3 or a T2 invasion, and this will determine their subsequent therapy. This is an example of an MRI elastography to assess for fibrosis, cirrhosis, it's end-stage fibrosis. And so what we can do is submit waves into the liver, and then we can assess the severity of the fibrosis. So the red suggests a cirrhosis, the blue and the green mean more mild F1, F2 versus red, which are F3, F4 fibrosis. And we can get these wave images by an external coupler that sends waves into the liver, and that helps us identify the severity of fibrosis. This is now indication to assess underlying fibrosis because fibrosis is reversible, and so this has supplant hepatic biopsy to diagnose. As you can imagine, if you biopsy this area, you're not going to get much fibrosis versus if you biopsy this area. So there's sampling error associated with biopsy, and so imaging can give you a holistic evaluation of fibrosis. This is an example of another type of prostate or an MRI. It's called prostate MRI. The American Urology Association and the American College of Radiology now recommends MRI before any biopsy, before prostate biopsy. And so we can do this by looking at both anatomic and functional imaging. So this is a T2. This is the rectum back here. This is the pubic rami, and then you have the prostate. This is the T2 images. And then we can get what we call DCE, which is with arterial enhancement. We give contrast. And then we can get diffusion weighted imaging, these dark images down here. Diffusion weighted imaging looks at the water motion. So as you can, for example, if you take a sponge and you put that in water, you're going to get normal diffuse water motion throughout the sponge. If you had a pebble in the sponge, the area of the pebble is not going to take up the water like the normal sponge does. And that's the same thing with tumors. Tumors are like little rocks. They're very hard, and so they restrict water motion. And this is what we see here. So in this patient, there's this lesion in the transition zone that's restricting water, and it becomes bright on what we call GWI and then dark on ADC. So this area of water motion restriction is consistent with prostate cancer. And here are the arrows pointing you to the. So just like liver, we use PIRADS, category 1, 2, 3, 4, 5. 5 means it's highly likely to be cancer, and this would be a PIRADS 5 lesion. With prostate, now we can do targeted biopsy using MRI specifically to then fuse it with the ultrasound images or do it directly in bore. This is an example of direct in bore biopsy, and this is an example of fusion biopsy. The ultrasound images are fused with the MRI images to help with targeted biopsy. And lastly, a note about gadolinium. Gadolinium is the contrast agent we use in MRI. And as of 2018, the American College of Radiology contrast media guidelines says we do not need to screen for GFR or creatinine if you're using type 2 gadolinium agents. For example, multihands is one example of a type 2 agent. So any patients can get multihands or any type 2 agent contrast enhance MR, abdomen, and pelvis without GFR. So if there's end stage CKD or hemodialysis, it's not a restriction or contraindication. In fact, patients, and it's so safe that there's no longer a threshold or a requirement for checking creatinine with type 2 gadolinium agent. We can also use oral contrast. For example, with enterography, the concept is the same. We can use negative contrast, as we saw an example of earlier, with MRI abdomen as well. And MR enterography is an example for evaluating IBD or small bowel pathology, and is preferred over CT because it has high soft tissue resolution. If patients are acutely sick or cannot tolerate it, then of course you're going to do a CT. But any young people, any individuals where you're trying to characterize Crohn's or IBD and patients are outpatients and not acutely ill or septic, then MR is preferred over CT enterography. So that's a summary of modalities used in abdominal radiology.